of my life. It's extremely embarrassing. So, welcome back to DrugsCo. Last week we did not quite finish tripsitting. There's only like a tiny little bit more information in there. And sorry if it's kind of loud outside. I guess my roommates are playing basketball again in the house, I guess. So, and Mario Kart at the same time, it sounds like. It's very active in here. I feel so sick. So, we're going to finish up tripsitting, just a little bit of information about adulterants, and then get into addiction and dependence and overdose. So this is a really important series of lectures. Unfortunately, it's not very visually appealing because I was so burned out by the time I made these slides 2 years ago that I just kind of was like, fuck this, they'll be mostly text. So I'm sorry they're not as fun. Here we go. So let's see. Whoops. It's so loud out there. It's so distracting. So last thing we talked about was how to kill a trip. And the gist of this is basically that none of these drugs are guaranteed to kill a trip. Some of them might be effective in reducing either the psychedelic aspects of the trip or the anxieties associated with the trip. But kind of the issue here is that if you introduce these drugs into the system, you run the risk of having someone either have a really, you can't hear any basketball or Mario Kart from here. It's so loud out there. It is like actually like, it sounds like a frat house and there's only 3 people in the living room right now. So these methods are like in case of emergency. The only times that I've had to administer trazodone to someone were once in the mountains of Northern California at a little underground event where someone was convinced that they were dying and bleeding for hours at a time and couldn't say anything except, oh my God, help me, help me, help me. And there was no way to get medical assistance or sedation or anything for her. And she was like having such a traumatic experience that was unreachable that it killed the trip. And then the other time was someone who was ripping all of their clothes off, running around the house naked, screaming, I own you, I own you, I own you, and like just saying everyone's names over and over again. So those were the situations in which I've personally administered these in the past. There are absolutely contradictions to these medications. As I think I mentioned this last time, so you might want to go over the last lecture for a more comprehensive picture because I got to go kind of quick today. Antipsychotics, generally speaking, are not particularly pleasant drugs. They often make people feel very foggy. There's a reason that people don't take antipsychotics for fun, you know, and it's because they're usually dopamine antagonists. So remember, dopamine is the reward and motivation chemical, and dopamine antagonists can make people feel pretty numb. And then trazodone is an atypical antidepressant. I don't remember its exact mechanism of action, but I think it might actually be a serotonin antagonist, but that could be wrong, so look that up. Benzos are quite dangerous to combine with any other depressant, and they will not necessarily kill the trip, but they would calm the mind in some cases. However, benzos have their own slew of complications that we'll actually go over today. So if you have more specific questions about this, you can either look at last lecture or message the chat or pop in and ask a question if you want, but for now I'm going to keep this ball rolling. Now, I know that I mentioned this in the past, but 25I-NBOMe is one of the few adulterants of LSD that I would say is actually pretty dangerous and to look out for. It's quite dangerous. I'll actually elevate that. If it's bitter, it's a spitter. I know that I've said this before, and another thing that I've said before is that your dealer might tell you that it won't work if you swallow it, and that's just patently false. You can absorb LSD through any mucous membranes, so if your dealer is like, you have to keep this in your mouth, that is a red flag. Frequently, the trip on 25I is considered to be a lot darker and wilder, and the dose is way higher than LSD. So a typical dose of LSD is 100 micrograms. 25I-NBOMe is around 800 to 2500 micrograms. So that's 2.5 milligrams in the very high range of doses. And 25I is notorious for inducing seizures. It is very, very seizure prone. It's caused cardiac arrest and hypertensive crisis. And people react very unpredictably to 25I, and it's quite a chaotic chemical in that way. So remember, if it's bitter, it's a spitter. Does anyone remember what other... This is not the one that lasts 24 hours. This, I think, is around the same duration as LSD, I believe. Yes, it does have more body load, although that's kind of subjective, but it has more body load, I'm pretty sure. Does anyone remember which acid adulterant that's also bitter, that is not a very common adulterant, but does anyone remember which X class of drugs that is a psychedelic? It does last up to 24 to 36 hours. Anyone know this? No? Okay. That is the DOX family. So DOI, DOC, DOE are all very long-lasting, very bitter, very chemical-tasting psychedelics. So if someone, so if someone is ever like, oh, my friend took this tab and was tripping for 2 days, then chances are, unless that tripping was actually a psychotic episode, that person was probably on a longer lasting research chemical, and Occam's razor, most likely that would be in the DOX family. Not necessarily lucky guy if you have literally anything happening in your life that you need to be sober for. Then there are the MDMA adulterants, or pretty much anything that is claimed to be adjacent to MDMA or stimulants, but all of these things come in crystal and powder format that looks identical to MDMA or MDA. Like, I cannot stress to you guys enough how completely impossible it is to identify a substance by looking at it, or smelling it, or tasting it, or touching it, or even doing it. You cannot. You cannot. You can take the exact same molecule, make a tiny, tiny little tweak to it, and have it be a completely new chemical that looks, smells, tastes, and feels pretty much exactly the same as something else, but has a totally different toxicity profile. And even the most discerning brain, like it's set in the setting, is going to change your experience. Your body chemistry at that moment is going to change your experience, like your environment, your food intake. It's all going to impact your experience. You are not advanced testing technology. Don't take yourself so seriously. Buy a test kit. We'll come back to that. So synthetic cathinones are bath salts. That's what this class of drugs is colloquially known as. Some common bath salts are MDPV, methylone, alpha PVP, and mephedrone. And these are often described to have kind of the like euphoric sensations of MDMA and the stimulating sensations of amphetamine. However, it should be noted that, and we're going to come back, I think, to these a little bit later. Actually, I think in like 1 or 2 lectures, we'll look at these more in depth. But these are like classic stimulants in a lot of ways that also include kind of a physical, tactile, sociable element to them as well. Now, one of the biggest issues with synthetic cathinones is that they frequently have a pretty high addiction risk because stimulants are just so rewarding in the first place. And stimulants that are used in recreational settings, this includes Adderall, this includes all stimulants, do have a higher potential for compulsive redosing and psychological dependence in social situations. So these are not just like some magic combination of other drugs, just as Adderall is not some magical safe thing just because it's prescribed. And in addition to this, I hope my computer doesn't die. Oh shit, my computer might die. Pause. One minute, please. Sorry. I was making the world's most delicious pork chop before this. That's what I was doing. Anyway, so classic stimulant effects happen from synthetic cathinones, but you should also really look out for blood pressure. This is a major thing here. A lot of the crises that come from stimulants of any kind are because of hypertensive crisis, which can even happen to people with low blood pressure at normal doses of things. Hypertensive crisis can happen to anyone, as well as dangerously heightened heart rate. And you might not expect it, but these things can have really serious side effects depending on the person, especially if they're interactions. So these are dopamine agonists, serotonin agonists, norepinephrine agonists, and from this we can get a pretty complete picture of the effects of synthetic cathinones, right? So they're not going to make you a cannibal. That's like a common thing that's reported as like the flesh-eating bath salts of Florida, and Florida Man's at it again. And who is Florida Man? Selling something advertised for human consumption isn't always legal, so companies would label them as bath salts or fish food. Oh yes, thank you for answering that. Yeah, so actually you used to be able to get 2CB, which is another, I don't think we even talk about that in this class, I'll add it. You could get 2CB at gas stations. It was sold under the name Nexus. There are many head shops, sex shops, gas stations that sell potpourri or bath salts or whatever as just like a legal high, or like a performance enhancing stimulant, which can be super dangerous to combine with other drugs, especially because you don't know the toxicity profile. So people actually, I think MDMA was also sold in gas stations at one point, if I remember correctly. Yeah, paranoia and psychosis are really common for chronic users of stimulants in general, including synthetic cathinones. Just if people are not getting sufficient sleep or are taking excessive doses, that's a pretty major risk. So harm reduction for cathinones, which many people do recreationally, is ensure that you're getting enough sleep, satisfy your physiological needs, and make sure that you're keeping track of your dosing, because oftentimes overdoing it with cathinones can lead to pretty serious come downs and hangovers and discomforts, etc. Okay. Now, time for today's lecture, which is overdose and addiction. Super important stuff in here, especially if you're a ground controller. I see you. But before we do that, what is the phrase for when time seems to be all messed up? "2020. Good times. Okay, come on. What is it called when time is all fucked up? Tripping. Okay, well, yes, but you're super close. Yeah, distorted time perception. That's what I'm referring to. But like, what's the phrase for distorted time perception? When time seems...
I was thinking temporal displacement, but that's not it.
You're on the right track. It's time dilation. So if someone is going through time dilation, it might seem like time is going too fast or too slow or repeating itself. But dilation usually means like it's stretching out. Like dilation implies that time seems like it's going on and on forever. What is, if it's bitter, it's a spitter refer to? There are a couple answers here. I see N-bombs. And what is the other class of drugs that we just referred to last time? Like, as in 5 minutes ago. Yes. So 25I N-bomb is the main thing that we're looking out for with if it's bitter, it's a spitter. And unfortunately, we are seeing a resurgence of it on the illicit market right now. On drugs data, we are seeing additional 25I sales for the first time in a couple of years. So please be careful of this. Be wary. It's not crazy likely, of course, that your acid will be adulterated in general. Acid is a pretty low adulteration drug, but tripping for 14 hours and having a seizure, or tripping for 36 hours unexpectedly, can really throw a wrench in your plans and maybe in your melon. So be careful. And then there's also the DOX family. So DOI, DOC, and that's all one thing. It's just DOC, DOI. There's no dash or anything in it. 25I-N-BOM is the name for the other one. After how many hours of sleep is a person likely to experience psychosis? Hours without sleep, that's what I mean. Approximately. This is like a ballpark, where after someone hasn't slept in this long, like your likelihood of experiencing psychosis is very high. Yes, 3 days. That's right. 72 hours without sleep, and your risk for this is like a general thing. You know, this is not something that I'm pulling from a scientific article. This is like, generally speaking, if someone hasn't slept in 3 days, that's about the point where you start actively hallucinating, generally. Yeah, even without drugs. Anyone in general that's staying up for that long, you are at high risk of hallucination. You're legally drunk after, I think, like a certain number of hours of wakefulness. I can't remember what it is. It's very short, though. It's like 24 or 27 hours or something of being awake. You're like legally drunk. Now, we are supposed to do a reagent testing demo here, but for the interest of time, I'm just going to kind of walk you guys through it. There is, I have good news for you in case you're not already aware, a way to test your drugs at home. But most people actually totally misunderstand what these test kits are going to be used for and how you can use them effectively. So don't fear, I'm here to set the record straight because I'm really tired of this and we need better messaging as dance safe as well. So when you're using these kits, the first and most important thing to know, and if anyone is a regular kit user, I have infographics that I can send you that detail all this information in 2 easy things. When you use a test kit, you are testing the primary detectable components of your sample. So this is kind of sticky because some things, when you are like dropping these chemicals on your sample, their reaction is no reaction. And other things will like turn black or turn blue or something like that. So I'll come back. Did I already tell you guys the example of PMA versus MDMA? Did I tell you guys that one? Anyone remember? Okay, I'll reiterate it. Let me make this very clear. I'll come back. Thank you, Danita. Using a test kit cannot tell you the purity of your substance. No, it can't. It's not a purity test. There is no effective at-home purity test. Yes, they exist on the market. You can buy an at-home purity test. No, they don't work. They're not reliable. It is a waste of money. If it were that easy, then we would be selling them as well. It's hard to make these things happen. No, your test kit cannot tell you accurately and actively if there are multiple things in it. No, your test kit cannot tell you how much of everything is in it. It cannot tell you how good your substance is. The purpose of using a test kit is to say, is my substance mostly not what I want? Okay, so this is a process of elimination. This is for you to be like, oh, I thought that I had MDMA, but it's reacting as though I have MDPV. And that is like not what I'm looking for. So ergo, I'm going to get rid of it, or I'm going to not do it, or I'm going to do it, but know that this is a risk. As opposed to being like, I have MDMA, or I was sold MDMA and it turned black on all these things, so I have pure Molly. That's not it. That's not it, Chief. A lot of people do this because they want to feel better about what they're about to ingest and they want to feel very secure in it. Unfortunately, that's just not how these kits work from a scientific standpoint. So don't be like that. Now, taking a look at what these reagents actually do, they contain sulfuric acid, and they're known as like the single bottle, the single chemical is known as a reagent, and they're usually named after the person that created them. These are highly toxic and corrosive. I can tell you from personal experience, if you drop one on like your pants leg by accident, or like you drop a drop of it in your pants leg and don't notice it for like 5 minutes, there will be a hole burned in your skin. So be careful when you're using these. I always advise using gloves, although I'd be lying if I told you guys that I always use gloves. But I really advise using gloves because chemical burns are very painful and can be really serious, especially if you're not experienced with these. They used to be kind of a thing in some dance safe chapters that you would come away from an event at the end of the weekend with no fingerprints, which to me is a sign of like you need to be using gloves. That's not good for you. They react to a unique set of chemicals. So each of these reagents has a set of chemicals that it reacts to and a color that it turns in the presence of those chemicals. But for many of them, let me go back. For many of them, let's say for instance with the Marquis reagent, Marquis would turn black with both MDMA and MDA. So that's a problem, right? If you're using Marquis only and it turns black, then it could be 2 things. So you need more reagents to narrow it down. Does that make sense to you guys? Can I get thumbs? Does that make sense? Okay, we got some half-hearted thumbing going on. If it doesn't make sense, let me know. We can move on. So you need a panel most of the time, and if not all of the time. And a panel consists of multiple different reagents that you're using in conjunction with each other to identify what your drug is. Now, this is why you need multiple reagents. A lot of people just buy the Marquis or like one single kit, one single reagent, and they just use that and they're like, well, I have pure Molly. I'm like, okay, you need to read the instructions more carefully. So if you have a spread like this, like you have Marquis, Mecchi, Mandolin, which are just 3 of the names of different reagents, you can basically read across the chart and be like, oh, this one turned black and this one turned black and this one turned black. Now to differentiate these 2 drugs, I have to use this one, then it will turn blue, and then I know. Like you use the conglomerate picture to get an idea. Usually this is the part where I would do a demo, but for now I'll just tell you that reagents, if you put them in a fridge or freezer, last about a year to a year and a half, and there are about 50 to 100 uses per test kit. So this is a really, really economical thing to invest in with your group of friends or your rave fam or whatever the fuck it is that you're doing these days, or your hamster or your next door neighbor. I don't know what kids are doing. So this is very cheap if you really actually divvy it out. It costs like less than $1 per test if you use the entire panel. And this is for a 4-panel. I advise getting an 8-panel, which is more collective and also includes a kit for testing what's called an indole, like LSD. Come back to that. So here's what the chart looks like. So you can see what I'm talking about here, where if you only have one of these reagents, right? Let's say we only have the mandolin reagent and it turns green. Well, that's great, but now you don't know if you have meth or amphetamine. That really influences how you do this drug, right? So you would look at this chart and be like, okay, which other reagent do I need to use to differentiate between the two? You would identify the Simon's reagent. You would use that on it, on a new little bit of your sample. And then you would see, oh, it turned blue. I have meth. Whoops. Or maybe yay. Who knows? So that's the gist of how test kits work. I highly recommend asking questions before doing any at-home tests. And again, I can't stress this enough. The test kits can't tell you very much. They're really important, but they are not supposed to be used to confirm that whatever you're doing is what you think you're doing. It's only used to tell you if it is mainly not what you want. Okay. Now here's the Airlix reagent, the last one that I mentioned. This is for what are known as indoles. So this is a group of chemicals that includes most major psychedelic compounds like LSD and DMT, psilocybin, psilocin, etc. And it turns purple in the presence of all of these. If it's NBOME, if it's 25I NBOME, it won't react. So that's what this is being used for, is to rule out 25I NBOME. If it's purple, it's not NBOME. If it's not purple, it's either NBOME or something completely different. Could be inert, but it might be NBOME. Now, something to keep in mind for using Airlix reagents is that sometimes they can take a long time to react, multiple minutes, whereas with these guys, the reaction will only be valid up through the first 30 seconds or so. So after 30 seconds, all of your little dots of color are going to start running and getting kind of weird looking and blotching, and you might have like a black reaction that turns red and be like, my Molly's heroin. That's not the case. 30 seconds is your window. Airlix can take 5 minutes, might even take like an hour. So just let it sit there. High altitude tends to do that. Now, there's fentanyl strips as well, and that's also a really important thing that I wish I could demo right now, but we're going to run out of time. So there's this thing called the chocolate chip cookie effect, and I'm recently gluten-free, not by choice, and looking at this picture of chocolate chip cookies, I will have you know, has me actively salivating to a disgusting degree. So the chocolate chip cookie effect is when you have a baggie where only a little bit of fentanyl is in it. And a fatal dose of fentanyl is like a grain or two of sand, or can be fatal, a grain or two of sand. So this is a problem, right? Like if you're only scraping a little bit out of your bag to test it, then you're not going to know if there's just like a grain or two of sand hidden somewhere in your baggie of white powder. Now, a lot of you, I'm sure, might think, oh, but like, I'm not buying anything that would have fentanyl in it. Like, that sounds really far from home, man. I just would buy like maybe some Coke or some Molly or some Speed or whatever. The fact is that fentanyl is often distributed kind of by accident through cross-contamination. It's so tiny that it can get mixed up in all kinds of shit. So just, I want to say a week or two ago, we got a report in from, where was it? I think the suburbs outside of Chicago, that there had been like a massive spike in overdoses, some fatal, overnight from batches of cocaine that had gone around that were adulterated with fentanyl. This has also happened recently in Georgia within the last few weeks. A club owner died from doing a line of fentanyl, or a line of coke that was cut with fentanyl. This has been happening in Denver, in Boston, in New Hampshire, in Connecticut. It's all over the country. If you are buying white powder, or really if you're buying anything, you need to test it for fentanyl right now. It's not that hard. And I'll show you how. Not that funny. Anyway, we'll come back to, actually, no, I don't think we will. But when you're using fentanyl test strips, make sure that you read all the instructions properly on how to dilute your sample. You should ideally crush up, or if it's already crushed, then whatever, dissolve your powder in water that's properly diluted, given the number of milligrams of powder that you have, and then use the test strip. So read the instructions super carefully, otherwise you will get a false positive or negative, which can be really scary either way. Now let's talk about substance use disorders. All right?
Hey, can I ask a question about fentanyl testing?
Yeah.
So you're supposed to dissolve the entire drug and then test like the whole thing and then reconstitute it, right?
Mm-hmm.
In practical terms, isn't that like, that's a lot of trouble? Like most people aren't going to do that. Most people are just going to be like, yeah, well, I'm not going to, melt all my Molly or whatever and then try and bring it back. Like, is there a way to like get around this practical barrier?
That's a really tough one. I would say that Molly is a less likely issue. Like crystals are not as likely to be adulterated as powders is the first thing that I'll say, is that powders are like, if we're tiering this, like if we're creating a hierarchy of need and of danger, powders should be tested, all of them. And yes, it's an absolute barrier because it's really hard to convince people. However, what I will say is that when you dissolve your sample, your baggie, whatever, in a shot glass of water and you do the test, once the test is done, you just leave the shot glass out for like 3 days and the water evaporates out, and then you can just like crush it up and you have powder again. So you don't lose the drug by doing this. And that's a big misconception. But it is really hard to get people to do this at like a festival where they've just scored a gram of ketamine and they're like, no, I'm not going to make my ketamine liquid right now. That would be stupid. So the other, like really, I'm going to be honest with you. If you're not testing your whole sample with a fentanyl strip, I don't even know if it's really that worth doing the test at all. The only other viable option is scraping baggie residue into, or like filling the baggie with water and then doing that as a test, because that gives kind of a more comprehensive view of the outside of the powder. And the other thing you can do is use like spoon or cooker residue if you're a person who injects drugs. Yeah, you could indeed dissolve, test, and boof. I've tested someone's Xanax before where they've had it crushed up in a little thing and they've been like, I'm just gonna take it right now, and they just like drank it. So yeah, it's not ideal. It's really not ideal. If someone has a white powder that they purchased from the illicit market, especially if it's cocaine or any opioid right now, then if they won't test it properly using a test strip, then make sure that they're using around someone that has an Narcan and knows how to use it, because that could save their life. 4 minutes without oxygen to the brain is when you start getting serious tissue damage and brain damage. So substance abuse. This is a loaded phrase, right? Substance abuse is technically using a substance in ways that are not intended by a physician or using socially condemned substances. That's an important distinction to make, right? Like oftentimes people will say, if you're smoking weed at all, it's substance abuse. Now, no one's really defined abuse in this context, because who gets to decide what's use versus abuse? Generally speaking, for this course, we're going to err on the side of it is abuse if this use is directly problematic for someone's life. Now, within this, a substance use disorder consists of dependence, which is where the body requires the substance to function, and withdrawal is present in its absence, right? Like this is like, if you don't have this thing, your body is not happy, it's not functioning properly, or you have tolerance. But then on the other side of the coin, there may or may not be addiction, which is a neurobiological disease where your reward pathways in your brain are sensitized to one stimulus, in this case, a drug. And this needs to be both rewarding and reinforcing. So it has to be perceived as pleasurable, and a person must be driven to seek it out. Now, you can have addiction without dependence and vice versa. Your body doesn't necessarily have to be going through withdrawals or building tolerance for you to have like cravings and preoccupation and fixation. And you don't need to have cravings and preoccupation and fixation for your body to be really unhappy and not functioning properly without it. So substance use disorders kind of mix and match these things a lot of the time. And I will tell you in advance that I'm going to have to elaborate a lot on these slides because they are a little bit outdated, I would say. So dependence is split into two categories. There's psychological dependence and physical dependence. Physical dependence is when your body is in distress without the drug. And this is often things like alcohol, benzos, barbiturates, opioids, nicotine, cannabis. Yes, weed can make you withdrawal. Antidepressants, antipsychotics. And this is like not an exhaustive list. There are many, many things that can cause serious physical withdrawals. These are just some of the more notable ones that people can go through. And then there's psychological dependence, which is when your mental health is in distress without the drug. So this can be caused by a lot of different things. And it can seem unrelated to your drug use, right? So the difference between psychological dependence and addiction is often delineated by psychological dependence being like, I am in distress without this drug. However, I might not consciously be making the association with the drug. Like I might literally just be feeling really shitty psychologically. Whereas addiction is preoccupation with the thing itself. And this in turn can have consequences on your mental health. So psychological dependence, I feel shitty mentally without this substance, but it's not because I'm like craving this drug all the time. Addiction, I am unhealthily preoccupied with this substance. It's on my mind all the time. I want it. But my mental health might suffer as a result of that, and I'm not just like ambiently going through it. So some signs of addiction are that the person's life is getting interfered with, right? Like their school, their work, legal issues, conflict with other people. They have a really hard time controlling their use of the substance, even if they know that it's not doing good things for them or they have an unhealthy relationship with them. They spend a lot of time thinking about and fixating on this substance or getting this substance. They feel a sense of fear if they cannot get their hands on this substance. It can be sometimes used as a coping mechanism or continue to be used even though you know that there are consequences. Dependence, on the other hand, is either your mental state deteriorates for psychological dependence or your physical state deteriorates for physical dependence. And this often leads to insomnia and appetite changes. Those are two really big things that can come up here. Now, withdrawing from depressants is, think of it as though you have GABA, right? And you have glutamate. Now, these substances, depressants, will increase GABA activity and decrease glutamate activity, right? GABA is the neurotransmitter that's your natural anti-anxiety. Glutamate is the neurotransmitter that's your natural communication facilitator. If you're increasing natural anti-anxiety feelings and decreasing natural internal communication feelings, then you're going to basically be pushing down on a spring. You're like, okay, we're just going to lower our overall level of activity and strife and fear and whatever. And then as soon as you release that, these processes are reversed. So you can think of it as like, oh, I just thought of a really gruesome example I'm not going to use. Anyway, you can think of this as pushing down in a spring. If you release it, anything that you would expect to happen from a massive spike in activity in your body will happen. Sweating, insomnia, temperature regulation issues, being nauseous and agitated and anxious. Think like panic attack symptoms, including seizures, which is not a typical panic attack symptom. And also just generally having a hard time functioning, your muscles not really working as well. Alcohol withdrawals are extremely serious. If you're drinking multiple times a week, you can become dependent on alcohol physically. If you are binge drinking, which is 4 or more drinks at a time, yes, 4 or more standard drinks in a night can cause dependence as well. And drinking even a small quantity daily can cause dependence too. So even having a glass of wine every night for like months or years can cause physical dependence and withdrawals when you stop, even if you don't have any kind of mental preoccupation with alcohol. That was just a video of alcoholism. So most withdrawal timelines are at around the 1 day mark from your last dose. There are like 2 days of hell, 2 or 3 days of absolute hell. Then after a week or two, it really starts to taper off. But then the hardest part is the mental consequences thereafter. The hardest part for a lot of people is not getting through these first 2 weeks, even though they're super, super physically uncomfortable and very frightening. It's the continued abstinence thereafter. That's where most people get fucked up. In the process of alcohol withdrawals and benzo withdrawals, hallucinations are pretty common, seizures are pretty common, agitation are pretty common. These are all for serious withdrawals. This is for withdrawals like via alcoholism, right? Now, there are these things called delirium tremens, or DTs, which are basically when you are a really heavy drinker. And this is something that's experienced by approximately 5 to 20% of people who are in withdrawal. Around 15 to 40% of people that have DTs might die from them. They're that severe. However, this is a very treatable thing. This is like, if you have supportive care, it's not that dangerous. So this is why withdrawing from alcohol, you really need to be in a supportive care environment. Delirium tremens are frequently brought on by drinking approximately half a liter of liquor per day. So that's about 2/3 of a fifth per day can lead to something like delirium tremens. And this is just kind of a ballpark estimate. Now, DTs are notorious, and we'll come back to them again in a second, but part of the way that alcohol withdrawal can get so serious is this concept called kindling. It basically means that when you withdraw for a while and then like go back to it, each time your withdrawals will get worse and worse, and you'll need more and more to kind of stymie the withdrawals. Frequently, this can lead to really, really life-threatening levels of withdrawal. Very, very serious. So that's part of why it's really important if you're going through a detox process for alcohol or other similar depressants. Kindling is a really high risk. It makes you higher risk for everything. If you like stop progress of cutting something off and then go back to it, then your withdrawals will get worse and worse and worse every time. Now for benzos. This is a topic that I think is grossly understudied in drug education, especially because benzos are so popular among younger crowds, among adolescent and young adult crowds across the country and the world. A lot of people ask me, okay, like how can I use benzos in such a way that I'm not going to have a problem with them because they're so heavily underestimated? And the answer is variable, but here are some things you might not know. 2 or more weeks of using benzos on a daily basis can cause physical dependence. That means withdrawals. 2 or more weeks, that's not a long time. If your tolerance goes up, you either are already dependent or at risk of becoming dependent. So you really have to keep an eye on that with benzos. Thanks for sharing that, Orion. If you are regularly using on a weekly basis or more, it can lead to dependence in the long run. And it's not even that long of a run, like benzos are pretty quick. The time frame on this varies heavily from person to person. Benzo withdrawals are more notorious. Oh, all my videos are down. Sorry. Benzo withdrawals are notorious for being frequently cited as worse than heroin withdrawals and opioid withdrawals. Benzo withdrawals are serious shit. They are among the only withdrawals that not only can kill you, but you need to taper under physician guidance. Like you need to do this with help. And there's this other thing that we'll come back to in just a second called protracted benzo withdrawals. Generally, withdrawing from benzos just feels like massive discomfort, complete inability to sit still, and restlessness, extreme insomnia that can lead to other complications like psychosis eventually from lack of sleep, irritability and suicidal ideations, and pins and needles sensations, and like inability to keep food down. And all of this is the result of your brain just being like, after being pressed down for so long. Once again, about 1 to 4 days after your last dose, this is the general window for feeling really shitty is 1 to 4 days. That's going to be when your withdrawals are at their peak. And then for another 2 weeks or so, the withdrawals will continue. However, benzos are notorious for having withdrawals that can last for years, literally years. This is called protracted withdrawal syndrome. And we're going to return to it again, even more depth in a second. But one of the hallmarks of benzo withdrawals specifically is that each day the experience might be different. There's often very little continuity from one day to the next of knowing how your withdrawals are going to feel. And that's part of why they're so difficult. Approximately 10 to 15% of people that use benzos on a regular basis go through months or years of withdrawal symptoms. Sometimes this can cause cognitive deficits. Sometimes they're reversible, sometimes they're not. It can take 6 months or more for these things to improve. Sometimes they come in the form of people just being overly agitated about things or having a really hard time focusing or just having brain fog. It really depends. It can take a long time to return to normalcy after these effects have taken place. And frequently, people just don't believe that this is happening. This is a huge deal. Oftentimes people don't even realize that they're going through protracted withdrawal syndrome, and they just feel like they have some kind of terrible sickness for like a year or more, and it comes and goes and is in waves and is really confusing. If you know someone that's going through this, please be supportive of them, because this is the kind of experience where a lot of providers don't even know that it's happening, and benzos are being heavily overprescribed. So some harm reduction tips for withdrawing from depressants. Don't go cold turkey. Work with somebody else. Otherwise, you could be at risk of seizures and life-threatening consequences. You should taper over at least a month for benzos specifically. At least, bare minimum, but you should always work with a provider on this. Keep a daily record of how you're feeling and start cognitive behavioral therapy. This changes your habits because oftentimes coping mechanisms are damaged by this kind of experience. And you physically need to regrow neural pathways that can help you establish behavioral patterns and deal with the likely very increased level of anxiety that will come after benzo withdrawals. Depressants, generally speaking, reduce your natural anti-anxiety response, and CBT can help you start to reestablish those connections. Now for opioids. There's this thing called chipping. And it's basically when people just dabble. They just use opioids occasionally. Most of the time, through anecdotal reporting at least, chipping does not really work for most people. And never say never. It can in some cases, but chipping oftentimes does not lead to successful outcomes of being like a casual recreational user of opioids. It's not always that way, like like I said, sometimes it works, but often it doesn't really work. Dependence builds very quickly, and this can come on kind of unexpectedly for people that are like, oh man, I'm just feeling really shitty physically today, but I really need to get through the day, so I'll just like cut it tomorrow, and then sometimes that just keeps going. And especially if a person is like a working person who needs to be able to stay like with it all the time, this can pose a really serious cycle. Opioids are very sneaky, just like benzos. They're very sneaky. Even following prescriptions can still lead to addiction and dependence, although I need to stress that the psychosocial model of addiction is not talked about enough in this lecture. As with other drugs, 3 days, feel like garbage. Another week, still feel like garbage. Another 2 or another week after that, you're still feeling like garbage, but mostly mentally. And then you continue to kind of like have this weight lift slowly and slowly and slowly over time. But the real test here is after you've fully gone through the main part of the withdrawal. It's afterwards to see, psychologically speaking, if the person feels capable of continuing abstinence from a substance that they've had a problematic relationship with. Yeah.
I know, but you don't understand. I really love you. Listen, I love you, and I don't want you to die. And we all love you here, okay? So please, Mamita, take your medication. Tomorrow, I'll take you to a detox center. Oh, I can't. Please, Mamita. I can't afford to lose you. I can't. I cannot lose you, Mamita. I can't.
You're not gonna lose me?
Yes, I am. I'm losing you already. Look how skinny you are. I am losing you.
I'm listening to you.
Okay.
But I just want to leave and get high and just come back. I don't want to feel like this anymore. It's fucking killing me.
Well, that's what we're trying to help you. I'll put alcohol. You'll get.
Mom, you already did that, and I still hurt. You already
Okay.
did.
One of the major parts of withdrawal is a feelings of pins and needles. Oftentimes going through opioid withdrawal makes your skin extremely sensitive and painful. So kind of like close contact can feel really agitating and irritating. Tempers run high. It's a very stressful experience because you feel so ill. And in that moment, you're just like, fuck, I'm so close to not feeling ill. I'm so close to not feeling like garbage right now. Like I could just fix it right now and just like I'll figure it out after that. And that's how things start to go wrong. Now for overdoses in these 3 different major categories, so you guys know what to look for overdosing, because this is a really important thing. I put out a poll on DanceSafe recently that said, what is a seizure often a sign of? And there were 3 options: opioid overdose, serotonin syndrome, and something else, alcohol poisoning. And hella people put opioid overdose, having like seizures be a major sign of it, when that's really mostly for serotonin syndrome. So it's really important to know what overdose looks like for each different thing, because just lumping it all together as opioid overdose because someone isn't responding is not going to help anyone. With depressants, a person's overall bodily activity goes down. They might have slurring, loss of consciousness, blue lips, decreased oxygen to their extremities, decreased heart rate, and blown out pupils, mydriasis. Now, depressants, remember, act predominantly on GABA and glutamate. Then there are stimulants, and an overdose on stimulants will often consist of everything being too high, and this can result in seizures and sweating, like too much activity. Remember, seizures are the result of too much activity in the brain or irregular activity in the brain, and stimulants can disrupt that. If a person's heart rate is way too fast, if their blood pressure is way too high, if they feel like a pounding, thumping in their brain, if they're becoming delirious, if they're having seizures, this is often more an indicator of something going on with stimulants. Remember, stimulants impact dopamine and norepinephrine. And then there's opioids. Regardless of the kind of opioid, it's the same general thing as depressants, of everything going down, but instead of your pupils being blown out, they're going to be constricted instead of that. So if someone is, and pupils aren't always blown out on depressants, this is kind of a tough one. It can be hard to distinguish between depressant and opioid overdose. But you should always Narcan someone if they're showing signs of having a depressant or opioid overdose, because it will not hurt them if they're not under the influence. Yeah. 3 steps to handling overdoses. The first is identify what's going wrong. Try and identify the substance responsible if possible. If all functions are decreased, it might indicate a depressant or an opioid. If their pupils are constricted, it might indicate opioid. If they're dilated, it might indicate benzos or alcohol in some cases. If you think that a person might have ingested alcohol, smell their breath, sorry. If you think that they might have been using any kind of opioid, you can see if their pockets have tin foil or lighter in them, or any kind of cooker residue or any baggies. You can also check their wrists, their arms, their ankles for track marks, the signs of injection sites. If they're unconscious, stabilize them. This consists of ABC, airway, breathing, and circulation. So make sure that their airway is clear, check to see if they're breathing, and make sure that the heart is still pumping, basically. Everyone should know how to do CPR. You could very easily actually save someone's life doing CPR, even if it's just someone that you pass by on the street that's having a crisis. We're going to go over the next step, which is the recovery position, in just a second. But before you do anything, call an ambulance. Always call an ambulance. Even if this person comes out of it, have an ambulance there. You don't know what's going to happen after that. Don't wait for them to wake up. If a person is unconscious and not responding to you, and this is important, like, I've come across plenty of people who were just passed the fuck out and almost had to call 911 until you just, like, do something and they're like, well, 5 minutes later, which is really just disorienting. If you come across someone who's unconscious and they're not responding to, like, being pushed or, like, slapped a little bit, you can do what's called a sternum rub, which is where you take your fist like this and this part of your knuckles and find their breastbone and push down and rub really hard and fast. It's very uncomfortable. Push hard, rub hard. It's quite uncomfortable. If they're out and they're gonna wake up, they'll wake up. Trust me. That should be used as a last resort, though. You don't just want to, like, approach someone who's sleeping and give them a sternum rub. That's really rude of you. It hurts for, like, a while afterwards. So check first. Make sure that they're actually not conscious before doing anything. Make sure that they're actually not responding. You can put your hand over their mouth to see their nose and mouth to see if they're still breathing. You can put your fingers right here to feel a pulse for them. You can put your fingers on their wrist to feel the pulse for them. Call 911 and then CPR. And then afterwards, you want to watch for, or during this, you want to watch for a couple of things. Hypoxia is the number one danger for most of these, a lack of oxygen, right? And a lack of oxygen can cause heart failure, which can cause seizures, which can cause death. Although seizures are not the main concern here. If a person's lips or fingertips or toes are turning blue, or even the tip of their nose are turning blue in any way, shape, or form, that could be a sign of too little blood flow to those areas. If a person is making gurgling or gargling noises, this does not, oh my god, I cannot stop burping. Why? Every time. This is not necessarily a sign that they're, like, breathing. It means that they might be having what's called agonal breathing or agonal breathing. I actually don't know how to pronounce that correctly. I think it's agonal breathing. You also want to make sure that there is nothing in their mouth. No puke in their mouth. Open up the jaw, poke around with your flashlight and your pinky finger, and make sure that there's no puke blocking their airway, because that's a big problem. If there's anything in their airway, try to get it out of there. And the way that you would do that is tilting the head back like this and pulling open the jaw. And that opens the airway for them if there's any issue with the airway being blocked. Look out for agonal breathing, which is kind of like, it can also be due to cardiac arrest. So it's not necessarily because they're just, like, breathing in weird ways. It could be because their heart is failing. There's so much shit happening in the room next door to me right now. I feel like I'm at a sleepover. Can tilting their head back cause something to fall deeper into their airway? If there's no blockage, no. If there is blockage, it gets a little messy because you usually don't have the tools. Like, if something is so deep in the airway that you opening the airway is going to force it further into it, there are bigger fish to fry here, you know? Your priority should be trying to pull anything out of their airway that's immediately visible. And if there's nothing immediately visible, tilt their head back, open it up like that. Then there was the recovery position. And if you guys were fortunate enough to be in a classroom with me right now, I would be demoing this right now and complaining the whole time. So if someone is unconscious, or if they're alcohol poisoned, or really just in general, if you need to have someone lying down who can't move themselves, put them in the recovery position. This is on their left side. Their left, like this, left side. So you're going to roll them onto their left side. You're going to put their left arm like this. And then, this is really hard to do, and I'm not laying down. Anyway, the point of it is that you want to use this hand to prop their head up on their other arm. I encourage you guys to all, like, lay down and do this. It's really hard to do like this. But the idea here is that you want their head not to be fully back like this, because that's a really easy way for stuff to get trapped in the airway. Lying on their left side helps move things through their stomach, so if they need to force it up, they can do so more easily. And also this means that they're not going to like roll over onto their face by having this elbow like this right here. Then also the knee over like that will prevent you from rolling onto your stomach, which is a really bad position to be in as well. So this also allows for a person's airway to drain. If their head is down and open a little bit, like not all the way down, but open a little bit, and on that left side, then stuff can come out of their mouth. Oftentimes when you put someone in the recovery position, just like a big glob of spit will just like come right out, and you can see how that could be helpful. This is the last thing I'll show you guys. It's completely irrelevant. It's just so much fun. Hey guys, thanks for coming to DrugsCo. I'll see you on Thursday. We'll finish that up and then move on to some of the last bits. Have a good night.